Welcome to today's deep dive. So, for decades, we've basically treated osteoarthritis like a pair of old worn-out sneakers.
Yeah, exactly.
Like you get older, the rubber tread on the bottom wears down to the foam, your knees start to hurt, and that's just the inevitable depressing price of gravity and time.
Right. It's the wear and tear myth.
But what if the medical community suddenly realized that the joint isn't just passively wearing away? What if it's actually this active, chaotic, metabolic war zone? And losing just like 11 pounds could essentially negotiate a ceasefire for you.
I mean, that wear and tear myth is arguably one of the most pervasive and damaging misconceptions in modern medicine today.
It really is.
We have millions of people, roughly 32.5 million adults in the U.S. alone, walking around with this diagnosis, assuming their joints are just, rusting out.
Right, like an old hinge.
Exactly. But age and gravity alone are entirely insufficient to cause osteoarthritis. If you look closely at the synovial joint under distress, you don't see a passive fading away.
You see something much more aggressive.
Oh, absolutely. You see a highly complex cascade of cellular destruction, biochemical signaling, and really a desperate, failing attempt by the body to rebuild itself.
Which completely flips the script for anyone stepping into a clinical environment. I mean, if I'm approaching this deep dive as a medical student trying to map out a treatment plan, I can't just throw painkillers at a rusting hinge.
No, you definitely cannot.
I need to understand the actual biochemistry of this war zone. So for everyone listening, our mission today is a clinical masterclass. I'll be the curious medical student, and I've got a veteran clinical pharmacist here to guide me and you through the pharmacist's patient care process.
I'm ready when you are.
Awesome. So let's zoom in on the joint itself. A healthy synovial joint has this beautiful, smooth layer of hyaline cartilage capping the ends of the bones, right? It's bathed in synovial fluid.
Yes, it seems very simple on the surface.
Right. But the data shows the early stages of osteoarthritis, or OA, don't start with the cartilage cracking. It starts with the cartilage actually taking on water. It swells.
It does.
Why would a joint breaking down start by filling up with water? That makes no sense to me.
Well, to understand the swelling, we really have to look at the microscopic architecture of the cartilage itself. Because hyaline cartilage doesn't have blood vessels.
Right. It's vascular.
Exactly.
Mm-hmm.
It's a highly specialized matrix made primarily of type 2 collagen and these massive molecules called proteoglycans.
Proteoglycans. Okay.
Yeah, and you can think of proteoglycans as microscopic, incredibly thirsty sponges.
Thirsty sponges. I like that.
They are highly negatively charged, which means they constantly draw water into the cartilage matrix. And this water is actually what gives your cartilage its incredible ability to absorb shock.
Yo, so it's a feature, not a bug.
Exactly. When you jump, the water is temporarily squeezed out. When you land, it rushes right back in.
So under normal conditions, the collagen fibers act like a tight net that holds these thirsty proteoglycan sponges in place, keeping the cartilage firm and resilient.
You nailed it. The structural integrity relies entirely on that net. But in the early stages of OA, the chondrocytes, those are the specialized cells that maintain this whole matrix, they start to dysfunction.
Due to what? Just age.
A combination of genetic susceptibility and biomechanical stress, usually.
Mm-hmm.
And when they dysfunction, they begin releasing degradative enzymes, specifically matrix metalloproteinases.
Oh, that's a mouthful.
It is, yeah. But these enzymes act like microscopic scissors, basically snipping the tight collagen net.
Oh, wow.
Right. And once the net is compromised, those proteoglycan sponges are no longer constrained. They draw in excess water, causing the cartilage to literally swell and soften.
It's like a water balloon where the rubber has been stretched way too thin.
That's a perfect analogy.
It's swollen, but it's fundamentally weaker. And I was reading that this leads to a massive drop in the actual proteoglycan content over time.
Yes. Once the collagen matrix is loose, the proteoglycans begin to leak out into the synovial fluid, and they just get washed away.
And without them, the cartilage loses its shock-absorbing resilience completely.
Precisely. The chondrocytes try to compensate by ramping up production, but eventually they just undergo apoptosis.
Programmed cell death.
Right. The cartilage becomes hypocellular. The surface, which should be as slick as wet ice, begins to fibrillate. It frays, it splits, and it develops these deep vertical fissures.
And once that buffer is compromised, the damage doesn't just stop at the cartilage, does it? The sheer mechanical force of walking has to go somewhere.
Right. The force transfers directly into the bone underneath the subchondral bone.
And this is where I encountered a term that sounds almost medieval: eburnation.
Eburnation is a really striking and painful pathological change.
What exactly is happening there?
Well, because the cartilage is fraying and thinning, the contiguous bony surfaces of the joint begin to grind directly against each other.
So it's bone on bone.
Exactly. And this persistent, intense friction causes the exposed subchondral bone to become highly polished. It literally takes on the dense, smooth appearance of ivory.
But it's not a healthy, strong ivory, right? The clinical descriptions mention microfractures developing beneath that polished surface.
Yes, severe microtrauma.
And even osteonecrosis, which is actual bone death occurring because the pressure is destroying the localized blood supply.
It's incredibly destructive.
It completely broke my initial mental model. I mean, I thought the bone was just getting scraped away like chalk, but instead the bone is dying from the inside out while simultaneously trying to armor itself on the outside.
That's the tragic irony of it. The body senses that the joint is becoming catastrophically unstable. And the skeletal system really has only one mechanism for dealing with localized instability.
It builds more bone.
Exactly. Following Wolff's law, which dictates that bone adapts to the loads under which it is placed, the joint haphazardly starts forming new bone at the margins and at the ligament attachments.
These are the osteophytes, right? The bone spurs.
Yes, the osteophytes.
I always pictured a bone spur as like a tiny, sharp needle causing a little pinch of pain. But looking at the pathology, these are large, chaotic, jagged, architectural additions.
They really are.
It's like the body is desperately trying to build scaffolding to stop the joint from wobbling.
That is a brilliant way to conceptualize it for you and the listener. It is an architectural overcompensation. The joint is failing, so the body throws up extra bone to increase the surface area and stabilize the structure.
But I'm guessing that backfires.
Completely. This new bone just encroaches on the joint space, restricts the range of motion, stretches the highly innervated joint capsule, and contributes massively to the pain and the visible deformity of the joint.
So it's a repair mechanism that ultimately destroys the village to save it.
Perfect description.
Which perfectly explains the clinical presentation you see when a patient walks into the clinic. Because we aren't looking for a general systemic ache.
No, not at all.
OA is primarily an asymmetric disease of the weight-bearing joints, right? The hips, the knees, the cervical and lumbar spine, and specifically the hands.
Right. The asymmetry is key.
So if a patient comes in and their right knee is agonizing, but their left knee is relatively fine, that asymmetry is a massive clue.
It's one of the first things we look for.
But the real diagnostic differentiator I found involves stiffness. Let's say a patient wakes up and their joints are incredibly stiff, but that stiffness only lasts for about 15 or 20 minutes once they start moving around.
That brief duration of morning stiffness is a critical diagnostic hallmark for osteoarthritis.
Why is that time frame so important?
Because it helps us immediately differentiate OA from an autoimmune systemic inflammatory disease like rheumatoid arthritis or RA.
Oh, I see.
In rheumatoid arthritis, the immune system is actively attacking the synovial lining of the joints, usually bilaterally and symmetrically.
So both wrists, both ankles simultaneously.
Exactly. And the resulting inflammatory soup inside the joint causes profound morning stiffness that often lasts for hours, sometimes the entire morning.
Wow, okay. So in OA, the stiffness isn't driven by a massive autoimmune attack. It's a mechanical issue. The clinical text refers to it as a gelling phenomenon.
Yes, gelling.
Yeah.
Think of the degraded synovial fluid and the frayed cartilage debris basically settling in the joint space while the patient sleeps or sits still for a long period.
Right, the joint just gels up.
Exactly. But once they stand up and force the joint through its range of motion, the physical movement redistributes the fluid, lubricates the remaining cartilage, and the stiffness dissipates rapidly.
Usually in less than 30 minutes.
Almost always.
But the pain remains, especially upon weight bearing. And then there are the physical signs that you can literally see or feel.
Like the crepitus.
Right, the crepitus, that horrible grinding, crunching sound when the knee extends, and the deformities in the hands. The clinical texts are very specific about the nodes on the fingers.
Ah, yes. Heberden nodes and Bouchard nodes.
Yeah, how do we spot those?
When you examine a patient's hands, those hard, bony enlargements are the visible manifestation of the osteophytes we discussed earlier.
The bone scaffolding.
Exactly. Heberden nodes appear on the distal interphalangeal joints, so the small joints closest to the fingertips.
Okay, Heberden equals fingertips.
Right. And Bouchard nodes appear on the proximal interphalangeal joints, the middle knuckles.
Got it.
When you see asymmetrical, hard swellings at these specific joints without the red-hot, pulsating inflammation of a gout attack, you are looking directly at the architectural aftermath of osteoarthritis.
Okay, so I have this patient in front of me. Their cartilage matrix is depleted, their subchondral bone is polishing into ivory, and their finger joints are structurally deformed by osteophytes.
It's a severe clinical picture.
It is, and as a medical student, my immediate overwhelming instinct is to reach for the prescription pad.
Of course it is.
The patient is in pain, I want to prescribe a chemical to stop the pain and hopefully fix the joint. But if I understand the clinical guidelines correctly, writing a prescription right now would be a fundamental failure of care.
It would be a failure to alter the trajectory of the disease, absolutely.
So what's the first step?
Well, before we even discuss molecules, receptors, and pharmacology, we have to establish the clinical framework. In modern pharmacy practice, we rely on the pharmacist's patient care process.
Okay, walk me through that.
It's a rigorous, cyclical methodology. Collect, assess, plan, implement, and follow up. And when we apply this process to OA, the data is unequivocal. Medications do not substantially modify the disease course.
Wow.
They are merely Band-Aids for the pain.
That is a staggering reality to confront. I mean, we have thousands of drugs in the modern pharmacopoeia, and none of them can actually stop the chondrocytes from dying or dissolve an osteophyte.
None of them. Zero. If you only prescribe an analgesic or an anti-inflammatory, you are essentially muting the fire alarm while the kitchen continues to burn down.
Oof, that's a bleak analogy, but it makes sense.
It's the truth. The underlying biomechanical forces destroying the joint are entirely unaddressed by a pill. Therefore, the absolute cornerstone of any treatment plan, the only interventions that can actually slow the mechanical destruction, are non-pharmacologic therapies.
And the most potent non-pharmacologic therapy is the one patients usually want to hear the least about, right? Weight loss.
Without a doubt.
We always hear the generic advice to, lose a few pounds for your joints. But when you actually look at the biomechanical data, the numbers are shocking.
The math is very sobering.
Right. The risk of developing knee osteoarthritis increases by nearly 10% for every single kilogram, about 2.2 pounds above a person's ideal body weight.
That 10% figure should change how every clinician approaches this conversation with you and their patients. Because the force exerted on a weight-bearing joint is not a 1-to-1 ratio with your body weight.
It's exponential.
Right, exactly. When you walk on a level surface, the force transmitted through your knee is roughly 3 to 4 times your body weight.
3 to 4 times, okay.
But when you walk down a flight of stairs, that force multiplies to 6 or 7 times your body weight due to the biomechanics of deceleration.
Okay, let me do the math on that. If a patient is carrying just 10 extra pounds of adipose tissue, that is not just 10 pounds of pressure on the knee. Going down the stairs, that is 60 to 70 extra pounds of sheer grinding force on a cartilage matrix that is already fraying and taking on water every single step they take.
And this is why weight reduction is a non-negotiable goal, particularly for a hip and knee OA. But the reversal of that math is incredibly empowering.
How so?
Studies demonstrate that women who reduce their body weight by just 5 kilograms, exactly 11 pounds, can halve their risk of developing symptomatic knee osteoarthritis.
Have the risk, literally 50%.
Yes, cut in half.
Just 11 pounds to cut the likelihood of a debilitating chronic disease by 50%. That feels like a medical miracle hiding in plain sight. It's vastly more effective than any drug we're going to discuss today.
By a wide margin.
But the implementation is where the clinical reality hits a brick wall. So let's introduce a hypothetical patient based on the clinical case studies.
Okay, let's hear.
A 68-year-old female patient presents with worsening left hip pain. She's clinically obese, the pain is deep, it's aching, and it's severely limiting her ability to move.
Very common presentation.
Right, we know she needs to lose weight, which requires a caloric deficit and physical activity. But how do you look at a patient whose hip is actively degrading, who experiences agonizing bone-on-bone friction with every step, and tell them they need to go exercise?
It is the ultimate clinical catch-22. We are asking them to utilize the exact anatomical structure that is causing them the most suffering.
Right. It feels cruel.
You cannot simply advise this patient to start jogging or hit the treadmill. High-impact loading will accelerate the aberration and trigger a massive inflammatory flare.
So what's the plan?
This requires a highly strategic, multidisciplinary approach, usually beginning with a referral to a physical therapist.
Yeah, the clinical texts emphasize very specific types of exercise. It's not just move more. They recommend isokinetic and isotonic strength training programs.
The goal here is to build the muscular scaffolding around the failing joint.
Like shock absorbers.
Exactly. If the cartilage can't absorb the shock, we need the quadriceps, the hamstrings, and the gluteal muscles to absorb it instead.
Okay, so what's isotonic?
Isotonic exercises involve muscle contraction with a change in muscle length like a controlled leg extension, which builds dynamic strength.
Okay, and isometric.
Isometric exercises, where the muscle contracts without the joint moving at all, are brilliant for patients in severe pain
Why is that?
because they can build muscle tone without rubbing the damaged joint surfaces together at all.
Oh, that makes total sense. I was also fascinated to see Tai Chi explicitly recommended in the clinical pharmacology guidelines.
Yes, Tai Chi is fantastic.
Right. Like, we tend to think of pharmacology texts as just sterile lists of chemicals, but here's an ancient martial art featured prominently as a primary intervention.
Well, Tai Chi is phenomenal for OA because it addresses multiple deficits simultaneously. It involves slow, controlled, low-impact movements that enhance joint flexibility and muscle strength.
But there's more to it than just flexibility.
Much more. Most importantly, it drastically improves proprioception and balance. Patients with OA often alter their gait to avoid pain, which leads to muscular imbalances and a much higher risk of falls.
Oh, so Tai Chi re-educates the neuromuscular system.
Exactly. It restores that mind-body connection to movement.
And for patients who can't even tolerate the weight-bearing of Tai Chi, the text strongly advocates for aquatic therapy, water aerobics.
The physics of water provide the perfect environment for a damaged joint.
Because of buoyancy.
Yes. The buoyancy of the water counteracts gravity, essentially offloading a massive percentage of the patient's body weight from the hip or knee.
And at the same time,
Simultaneously, the viscosity of the water provides omnidirectional resistance, allowing them to build muscle strength safely.
beyond exercise, the non-pharm intervention extends to physical biomechanical manipulation, right? Assistive devices, like a simple cane.
Yes, a cane can be a game changer.
But there is a very specific technique to using a cane that seems totally counterintuitive at first glance.
I know what you're going to say.
Right. If my left hip is the one with osteoarthritis, my instinct would be to hold the cane in my left hand to support that side.
That is the most common mistake patients make, and it actually exacerbates the problem. A cane should always be held in the hand opposite to the affected joint.
So for a bad left hip, the cane goes in the right hand. Walk me through the physics of that.
Okay, so when you step forward with your painful left leg, you simultaneously bring the cane forward in your right hand.
Right.
As you bear weight on the left leg, you also push down on the cane with your right arm. Because the cane is on the opposite side, it shifts your center of gravity away from the damaged left hip.
It essentially acts as a secondary weight-bearing structure.
Precisely. It reduces the joint reactive forces on the affected hip by up to 30%.
Wow, 30%.
Yeah. If you held it on the same side, you would lean into the painful joint, increasing the mechanical load and the grinding force.
It's pure leverage. It's fascinating. And for the knee, the guidelines mention tibiofemoral or patellofemoral braces.
Yes.
And we aren't talking about those flimsy elastic sleeves you buy at the pharmacy, right? But structured braces that can actually alter the alignment of the knee.
Unloading braces. They are incredibly effective for knee OA, particularly if the damage is isolated to one compartment of the knee, for example, the medial compartment, which is very common.
How do they work?
The brace physically applies a counterforce to open up that narrow joint space, preventing the bone-on-bone contacts during the stance phase of walking.
And what about the hands?
For the hands, an occupational therapist can provide custom splints for the carpometacarpal joint of the thumb. It essentially immobilizes it during heavy tasks to prevent further subchondral damage.
And wrapping all of these physical interventions together is a layer of necessary psychological intervention. The texts highlight cognitive behavioral therapy and self-efficacy programs.
This is a crucial, often overlooked piece.
Which makes sense because if you are in chronic pain, your brain learns to associate any movement with tissue damage.
Absolutely. The clinician has to actively teach the patient that, in the context of controlled physical therapy, hurt does not necessarily equal harm.
Right. Breaking the fear avoidance cycle is critical because if a patient stops moving entirely out of fear, their muscles atrophy, the joint capsule tightens, the synovial fluid becomes stagnant, and the disease accelerates rapidly.
Education is as vital as the physical therapy itself. You have to get them moving safely.
Okay, so we've built the foundation. We have our 68-year-old patient on a caloric deficit. She's doing water aerobics. She's holding her cane in the correct hand, and she understands that controlled movement is necessary.
Excellent start.
But she is still sitting in the clinic, and she is still in pain right now. The non-pharm interventions take weeks or months to yield structural benefits. She needs pharmacological relief today.
So now we cross the threshold into pharmacotherapy.
Yes. And looking at the consensus guidelines for initial treatment, the recommended first-line therapy is completely counterintuitive to the way most people think about serious pain relief.
The hierarchy of pharmacological treatment often surprises both patients and emerging clinicians, definitely.
What's the starting point?
For osteoarthritis in superficial joints, specifically the knees and the hands, the unequivocal, strongly recommended first-line pharmacological treatment is a topical, non-steroidal anti-inflammatory drug.
A topical NSAID.
Yes. Before we ever consider an oral pill, we utilize a cream or a gel.
I can hear the patient pushback in my head already, like, you're giving me a massage lotion for my degrading bone.
It's a very common reaction.
Right. There is a profound psychological bias toward oral pills. We swallow a pill, it goes into the mysterious machinery of the body, and it feels like real medicine. Slapping some gel on a knee feels like a homeopathic afterthought.
I get that, but the pharmacokinetic reality of topical NSAIDs is actually brilliant.
Explain that for us.
It is an elegant solution to a massive systemic problem. To understand why topicals are first line, you have to understand the catastrophic collateral damage caused by oral NSAIDs.
Okay.
When you swallow a standard NSAID pill like ibuprofen or naproxen, it enters the stomach, gets absorbed into the portal vein, travels to the liver, and is then pumped into the systemic circulation.
It goes everywhere.
Everywhere. It enters your brain, your heart, your kidneys, and your stomach lining, all just to deliver a fraction of the active molecule to the synovial fluid of your right knee.
It's like a systemic carpet bombing campaign just to take out one localized target.
Precisely. Topical NSAIDs fundamentally alter that delivery route. By applying diclofenac gel, which is currently the predominant commercially available topical NSAID in the U.S., directly to the skin over the knee joint, the medication permeates the stratum corneum and diffuses directly into the local subcutaneous tissue.
Bypassing the GI tract.
Yes, straight into the muscle, the joint capsule, and ultimately the synovial fluid.
So you are delivering the payload directly to the war zone. But does it actually stay localized? Does none of it enter the bloodstream?
A minuscule amount inevitably enters the systemic microcirculation, sure, but the systemic exposure is remarkably low.
How low are we talking?
Studies indicate that the plasma concentration of diclofenac after topical application is anywhere from 5% to 17% of what you would see if the patient swallowed an equivalent oral dose.
That's a huge drop.
Huge. Because the systemic levels are so negligible, you essentially bypass the severe gastrointestinal, cardiovascular, and renal toxicities that plague oral NSAID therapy.
The trade-off is incredibly favorable then. You get localized pain relief that clinical trials show is comparable to oral NSAIDs, but the only common adverse effects are localized application site reactions.
Right, maybe a mild dermatitis, some erythema, or an itchy rash where you rub the gel.
For a patient with a superficial joint issue, it is the safest and most logical starting point.
Absolutely.
But there is a massive anatomical caveat here, and it brings us back to our 68-year-old patient. Her pain is in her left hip.
Ah, man.
And the clinical guidelines explicitly state that topical NSAIDs are not recommended and, frankly, largely useless for hip osteoarthritis.
It comes down to basic human anatomy and diffusion kinetics.
Why is the hip different?
The knee and the finger joints are superficial. There is very little tissue between the epidermis and the joint capsule. The hip joint, however, is buried deep within the pelvis.
Lots of tissue in the way.
Exactly. It is covered by a thick layer of adipose tissue and massive, dense musculature. The gluteals, the tensor fasciae latae. Topical diclofenac simply cannot penetrate deeply enough in high enough concentrations to reach the synovial fluid of the hip.
So for our patient with hip OA, the localized topical strike is physically impossible.
Unfortunately, yes.
Which means we have no choice. We have to escalate. We have to cross into the realm of systemic oral pharmacology. We have to use the carpet bombs.
We do.
And looking at the pharmacology in these sources, navigating oral NSAID therapy feels like walking through a minefield blindfolded. We are forced to dive into the incredibly complex biochemistry of the arachidonic acid cascade and the COX enzymes.
This is where clinical pharmacy becomes a high-stakes balancing act. To understand the danger of oral NSAIDs, we have to understand the inflammatory mechanism they are trying to stop.
Walk us through it.
When the cells in that degenerating joint are under mechanical stress or dying, their cell membranes are damaged. An enzyme called phospholipase A2 cleaves a fatty acid called arachidonic acid straight out of the cell membrane.
And arachidonic acid is essentially the raw fuel for inflammation.
Yes. Free arachidonic acid is rapidly scooped up by a family of enzymes called cyclooxygenases, or COX enzymes.
COX, got it.
Right. These enzymes convert the arachidonic acid into various prostaglandins. Prostaglandins are potent lipid signaling molecules.
What do they do in the joint?
In the joint, specific prostaglandins, particularly prostaglandin E2, bind to nerve endings, massively lowering their threshold for pain. They cause vasodilation, bringing fluid and causing swelling. They are the biochemical engineers of the pain and inflammation the patient feels.
So logically, if we want to stop the pain, we need to inhibit those COX enzymes. We need to shut down the prostaglandin factory.
That is the goal.
And that is exactly what NSAIDs like ibuprofen, naproxen, and diclofenac do. But there are two different factories, aren't there? We have KOX1 and KOX2.
And the distinction between those two isoforms is the source of decades of medical triumph and tragedy.
Let's unpack that.
KOX1 is what we call a constitutive enzyme. It is expressed constantly, baseline, in almost all the tissues of the body. It's not primarily there to cause inflammatory pain. It is a housekeeping enzyme.
Housekeeping. So it produces specialized prostaglandins that maintain normal physiological functions.
Exactly.
This is the part that blew my mind. When we think of prostaglandins, we think bad, pain, swelling. But the prostaglandins produced by KOX1 in the stomach are the only reason your stomach doesn't digest itself.
It's a perfect biological mechanism. The COS1 enzymes in gastric mucosa produce prostaglandins that stimulate the secretion of a thick protective mucus layer and bicarbonate, which neutralizes stomach acid.
Wow.
They also maintain mucosal blood flow. Simultaneously, in the kidneys, COX1-derived prostaglandins dilate the afferent arteriole, ensuring the kidney gets enough blood flow to filter toxins.
And in the blood.
In the bloodstream, COX1 in platelets produces thromboxane A2, which is essential for normal blood clotting.
So KOX1 is the ultimate guardian enzyme. It protects the stomach, sustains the kidneys, and clots the blood.
Exactly. Now, COX2 is quite different.
The bad guy.
Mostly, yes. Under normal conditions, COX2 is virtually undetectable in most tissues. It is an inducible enzyme. Its expression is rapidly upregulated by inflammatory cytokines, sheer mechanical stress, and tissue damage.
So KOX2 is the specific factory pumping out the inflammatory prostaglandins, flooding our patient's arthritic hip.
Correct.
Okay, so looking at this logically as a clinician, the solution seems obvious. I want a drug that acts like a heat-seeking missile.
Right.
I want it to bypass the TOX1 guardian enzymes entirely, leave the stomach and kidneys alone, and exclusively destroy the KOX2 enzymes causing the joint pain. But the traditional NSAIDs, ibuprofen, naproxen, meloxicam, they don't do that, do they? They are non-selective.
They are entirely indiscriminate. A non-selective NSAID down blocks the hydrophobic channel of both KOX1 and KOX2. It shuts down both factories.
Routine.
By blocking KOX2, it successfully relieves the joint pain. But by simultaneously blocking KOX1, it strips away the protective mucus layer in the stomach, exposing the raw tissue to highly corrosive hydrochloric acid and pepsin.
And the clinical statistics on this collateral damage are terrifying.
They really are.
The sources note that up to 60% of patients taking non-selective NSAIDs will experience minor gastrointestinal side effects like dyspepsia or nausea, but the silent damage is worse.
Much worse. Asymptomatic gastric and duodenal ulcers develop in 15% to 45% of chronic users.
And the most severe complications, actual perforations where the acid burns a hole entirely through the stomach wall, or massive upper GI bleeds, occur in 1.5% to 4% of patients every single year.
You're prescribing a drug for knee pain and giving the patient a 1 in 25 chance every year of suffering a potentially fatal gastric hemorrhage.
It is an unacceptable risk profile for long-term management, especially in the elderly OA population.
Which naturally leads to the pharmaceutical industry's attempt to build that heat-seeking missile you mentioned, these selective TOX2 inhibitors.
Right. If we just tweak the molecule to only fit into the COX2 enzyme, we solve the ulcer problem forever.
The theory was scientifically sound. COX2 has a slightly wider active site channel, a side pocket that COX1 lacks.
Oh, that's clever.
Pharmaceutical chemists designed larger molecules, celecoxib, rofecoxib, valdecoxib, that physically could not fit into the COX1 enzyme, but fit perfectly into KOX2.
Did it work?
Initially, the clinical trials were a massive success. The rates of GI ulceration and bleeding plummeted. Patients had profound pain relief without the stomach destruction.
But then the medical community realized they had unwittingly triggered a cardiovascular nightmare. I remember reading about Vioxx, the rofecoxib scandal.
The Vioxx withdrawal is a watershed moment in modern pharmacology.
What went wrong?
By selectively blocking KOX2 while leaving KOX1 entirely uninhibited, these drugs created a catastrophic imbalance in the cardiovascular system. Remember how we said KOX1 in the platelets produces thromboxane A2, which promotes blood clotting and constricts blood vessels?
Yes, the clotting factor.
Well, it turns out that KOX2 isn't just a bad guy causing joint pain. In the endothelial cells lining the blood vessels, COX2 produces a prostaglandin called prostacyclin.
What does prostacyclin do?
It does the exact opposite of thromboxane. It prevents platelets from clumping together, and it dilates blood vessels. In a healthy body, thromboxane and prostacyclin exist in a perfect antagonistic balance, keeping blood flowing smoothly.
Oh, I see the domino effect. If you give a patient Vioxx, you completely shut down the COX2 factory, producing the anti-clotting prostacyclin.
Yes.
But you leave the COX1 factory running at full capacity, pumping out the pro-clotting thromboxane.
You tip the scales entirely toward thrombosis and vasoconstriction. The blood becomes stickier, the vessels constrict, and the risk of developing a sudden, massive blood clot in the coronary arteries skyrockets.
Wow.
Rofecoxib and valdecoxib were pulled from the global market because they were causing an unacceptable rate of myocardial infarctions and strokes.
Heart attacks.
Exactly. Celecoxib remains on the market today, but it carries strict black box warnings regarding cardiovascular risk.
And here is the truly insidious part of the data in these sources. It's not just the selective KOX2 inhibitors that carry heart risks. The guidelines are adamant that all NSAIDs, both non-selective and selective, with the sole exception of low-dose aspirin, increase cardiovascular risk.
That's right. The mechanism of increased blood pressure is universal among NSAIDs.
How does that happen?
By inhibiting prostaglandins in the kidneys, NSAIDs decrease renal blood flow. The kidneys respond by retaining sodium and water to try and boost the pressure.
Which makes sense physiologically.
Yes, but this fluid retention expands the blood volume, driving up systemic blood pressure and exacerbating conditions like congestive heart failure.
So we're trapped in an impossible clinical paradox. Patients with osteoarthritis are, by definition, an older demographic.
True.
This means they inherently have higher baseline rates of hypertension, atherosclerotic heart disease, and declining renal function. And the primary systemic medications we have to treat their daily agonizing joint pain actively threaten to destroy their stomachs, shut down their kidneys, and trigger heart attacks.
It's a tightrope walk.
How do you practically navigate this as a clinical pharmacist? If a patient has a high risk for a GI bleed, but oral therapy is the only way to reach their hip pain, what is the protocol?
We utilize strategic risk stratification. If the patient has a high GI risk but low cardiovascular risk, the guidelines suggest two valid approaches.
Okay, what's option one?
You can prescribe a selective KOX2 inhibitor like celecoxib, which spares the stomach.
And option two?
You can prescribe a standard non-selective NSAID like naproxen, but you mandate that they take it with a proton pump inhibitor, a PPI like omeprazole.
So you give them the carpet bomb NSAID, but you also give them a drug that artificially shuts down the acid pumps in their stomach.
Exactly, so that even when the protective mucus is stripped away, there's no acid to burn the tissue.
It's chemical shielding.
Yes. For patients with incredibly high GI risk, we might even combine a TOX2 inhibitor with a PPI. But the overarching absolute rule for all oral NSAID therapy is this: utilize the lowest effective dose for the shortest possible duration consistent with the patient's treatment goals.
It is never a take two a day for the rest of your life scenario.
Never.
Okay, but what if our patient falls into the absolute contraindication category? Let's say their kidneys are already functioning at 30%, or they suffered a myocardial infarction 6 months ago, or they actively have a bleeding ulcer. Oral NSAIDs are entirely off the table.
They have to be.
Historically, my immediate reflex, and the reflex of almost every consumer walking down a pharmacy aisle, would be to reach for Tylenol, acetaminophen.
And historically, you had been following the gold standard clinical consensus.
Really?
Oh, yeah. For decades, acetaminophen was heralded as the absolute first-line oral analgesic for osteoarthritis. It was viewed as the safe, reliable alternative to the toxic NSAIDs.
But something changed.
The landscape of evidence-based medicine has shifted dramatically in recent years. The current clinical guidelines have fundamentally demoted acetaminophen.
Yeah, the sources state that recent high-quality evidence indicates acetaminophen monotherapy is ineffective, or at best, only modestly better than a placebo for the long-term management of OA pain.
It essentially barely beats a sugar pill.
Why did we believe it worked for so long, and why is it so ineffective for this specific disease?
The mechanism of action of acetaminophen is still surprisingly murky, honestly.
Really?
Yeah, but we know it acts almost entirely centrally within the central nervous system rather than peripherally at the site of inflammation.
Oh.
It inhibits prostaglandin synthesis in the brain, altering pain perception, but it has virtually zero anti-inflammatory effect in the actual synovial joint.
It does nothing to quell the chaotic metabolic war zone in the cartilage.
Exactly. Because the peripheral drivers of OA pain are so strong, central masking alone is insufficient.
But the textbook still grants it a place in therapy. We haven't completely abandoned it.
We haven't abandoned it because, despite its lack of efficacy, it remains entirely free of the specific cardiovascular, gastrointestinal, and renal toxicities that make NSAIDs so dangerous.
Right, it doesn't cause ulcers, and it doesn't spike blood pressure.
Therefore, it remains an inexpensive, appropriate choice for very mild episodic pain, or as the absolute fallback for patients who cannot tolerate NSAIDs under any circumstances.
But we need to dispel the myth that acetaminophen is a benign, harmless drug just because it's available in giant vats at the grocery store. The sources are incredibly focused on its hepatotoxicity, liver damage.
Acetaminophen toxicity, both intentional overdoses and unintentional accumulation, is the leading cause of acute fulminant liver failure in the United States.
How does a painkiller destroy the liver? What is the actual mechanism?
When you take acetaminophen, the vast majority of it is metabolized safely by the liver into inactive compounds and excreted.
Okay, that's good.
But a small percentage is shuttled down a secondary metabolic pathway mediated by an enzyme called CYP2E1.
CYP2E1.
Yes, this pathway converts the acetaminophen into a highly reactive, incredibly toxic intermediate metabolite called NAPQI.
NAPQI, that sounds like a poison.
It essentially is a poison. Under normal dosing, your liver has a built-in defense mechanism. It uses an antioxidant called glutathione to instantly bind to the NAPQI and neutralize it before it can do any damage.
Okay, so the body handles it.
Usually.
Yeah.
But glutathione is a finite resource. If you take a massive overdose of acetaminophen, or if you chronically take high doses over days, you completely deplete your liver's glutathione stores.
And once the glutathione is gone, the toxic NAPQI is left to run rampant.
Without glutathione, the free NAPQI violently binds to the proteins and membranes of the liver cells themselves, causing rapid, irreversible hepatocellular necrosis.
The liver tissue simply dies.
Yes.
This is why the dosing parameters are so rigid. The absolute maximum daily dose is 4 grams per day from all sources.
Yes, and the all sources part is where the unintentional overdoses happen, right?
Because acetaminophen is hidden in hundreds of over-the-counter cold, flu, and sleep medications.
The classic scenario is an OA patient who takes their scheduled 3 grams of acetaminophen for their joints. They develop a winter cold, so they start drinking over-the-counter liquid flu medicine every 4 hours, not realizing each dose contains another 650 milligrams of acetaminophen.
Oh, no.
Within 48 hours, they have exceeded the toxic threshold and are in acute hepatic distress.
And the margin for error shrinks drastically if we introduce alcohol into the equation. The sources highlight a highly specific and critical interaction.
It is a lethal synergy. If a patient consumes more than 2 to 3 alcoholic beverages daily, chronic alcohol intake actually induces or ramps up the production of that specific CYP2E1 enzyme we discussed.
The enzyme that creates the toxic NAPQI poison.
Exactly. So an alcoholic patient taking acetaminophen will funnel a much higher percentage of the drug directly into the toxic pathway.
Consequently, they will deplete their glutathione much faster.
Exactly. For a patient who drinks regularly, the maximum daily dose of acetaminophen drops strictly to 2.5 grams, and many hepatologists would argue they shouldn't take it at all.
So, to summarize our oral options, NSAIDs are potent but carry a massive risk of destroying the stomach, heart, and kidneys. Acetaminophen is weak, and if not monitored perfectly, destroys the liver.
It's a tough spot to be in.
We need another tool in the pharmacological toolbox. And this is where the clinical guidelines introduce a drug that genuinely shocked me when I first read it. Duloxetine.
Duloxetine represents a fascinating paradigm shift in how we conceptualize and treat osteoarthritis pain.
Because duloxetine isn't an anti-inflammatory. It isn't a traditional analgesic. It's a serotonin-norepinephrine reuptake inhibitor.
Yeah.
An SNRI. It's an antidepressant.
That's right.
I'm trying to put myself in the room with the patient. How do I look a patient in the eye, a patient who has an x-ray showing bone-on-bone grinding in their knee, and explain that I am prescribing them a psychiatric medication to fix their structural joint pain?
It requires a profound educational conversation about the neurobiology of chronic pain. We have to separate the localized tissue damage from the central perception of pain. When a joint is actively degrading, the peripheral nerves in the joint capsule are constantly firing nociceptive pain signals up the spinal cord to the brain. Over years of unremitting stimulation, the central nervous system undergoes a pathological adaptation. It physically rewires itself.
This is the concept of central sensitization, right? The nervous system becomes hyperexcitable.
Yes, the clinical terms are allodynia, where normal stimuli are perceived as painful, and hyperalgesia, where painful stimuli are perceived as excruciating.
So the volume dial is stuck.
Essentially, the volume dial for pain in the central nervous system gets turned up to a 10 and the knob breaks off. Even if we could magically freeze the inflammation in the joint, the brain is still trapped in a feedback loop of amplified pain.
So how does an antidepressant fix the broken volume dial?
Well, the central nervous system has an intrinsic defense mechanism against chronic pain called the descending inhibitory pain pathway.
What does that do?
The brain sends signals down the spinal cord to inhibit or dampen the incoming pain signals coming from the periphery. This descending pathway relies heavily on two specific neurotransmitters to function: serotonin and norepinephrine.
Ah, and duloxetine is a reuptake inhibitor for those exact two neurotransmitters.
Exactly. By preventing their reuptake into the neurons, it forces more serotonin and norepinephrine to remain active in the synaptic clefts of the spinal cord.
It provides massive pharmacological fuel to the body's natural pain dampening system.
Precisely. It essentially repairs the volume dial and turns the gain back down. Duloxetine is particularly brilliant as an adjunctive option for patients who have achieved suboptimal relief from oral NSAIDs.
It makes a lot of sense.
It is also strongly recommended for OA patients who suffer from concomitant neuropathic pain or widespread musculoskeletal pain. It doesn't heal the cartilage, but it fundamentally alters the software processing the pain, bypassing the renal and gastrointestinal risks of NSAIDs entirely.
It's an incredibly elegant intervention. But let's say the central pain processing is controlled, or the patient refuses a daily oral pill. They want an intervention that tackles the hardware directly. They want to bypass the systemic route entirely.
This brings us to direct intra-articular interventions, injections.
Right. The most common request in any orthopedic or rheumatology clinic is the steroid shot. Intra-articular glucocorticoids like methylprednisolone or triamcinolone.
From a purely symptomatic perspective, a glucocorticoid injection is arguably the most potent, rapid-acting intervention we have.
It's like calling in an airstrike of highly concentrated anti-inflammatory agents directly onto the war zone.
The systemic absorption is minimal, but the local suppression of the inflammatory cytokine cascade is absolute. The clinical texts note that patients can experience profound, rapid relief within days.
It is the ultimate tool for a specific clinical scenario, right? An acute, severe flare-up of OA pain in a single joint, particularly if that joint has developed an inflammatory effusion, a buildup of excess fluid.
Exactly. A clinician can aspirate the fluid to relieve the pressure and immediately inject the glucocorticoid.
But reading the fine print in these guidelines reveals a massive, non-negotiable limitation.
Yes, there is a catch.
The sources dictate that glucocorticoid injections should never be administered more frequently than once every 3 months in a single joint. Why the hard stop? If it works so well, why can't we just inject them every month and keep them pain-free?
Because the intervention itself carries biomechanical consequences. First, there's an immediate paradoxical risk called a post-injection flare.
What causes that?
Glucocorticoid suspensions are formulated as microcrystals to ensure they dissolve slowly and provide lasting relief. However, when you inject these crystals into a highly reactive synovial space, the immune system sometimes recognizes the crystals as foreign bodies.
Wait, the anti-inflammatory injection triggers an inflammatory attack.
It's a crystal-induced synovitis. It mimics the intense throbbing pain of an arthritis flare or gout attack, usually starting within hours of the injection and lasting for a day or two.
That sounds awful.
It's generally easily managed with cold compresses and rest, but it's a deeply distressing experience for a patient who thought they were getting a pain relief shot.
That's the short-term risk. But the 3-month rule is based on a much more insidious long-term risk, isn't it?
Yes. There is robust, deeply concerning clinical evidence indicating that chronic, repeated exposure to high-dose intra-articular glucocorticoids actively accelerates the catabolic degradation of hyaline cartilage.
It destroys the cartilage.
The steroids suppress the chondrocyte's ability to synthesize new matrix proteins.
So if I can build on the fire analogy we used earlier, a steroid injection is like a heavy-duty chemical fire extinguisher.
That's here.
It is phenomenal for putting out an acute raging blaze in the kitchen. But the chemicals in the extinguisher are inherently caustic. If you prophylactically spray the extinguisher all over the kitchen cabinets every single week to prevent a fire, the chemicals themselves will eventually rot the wood and destroy the house.
That analogy is fundamentally correct. You are trading long-term structural integrity for short-term symptomatic relief, which is why these injections must be strictly rationed and reserved for severe flares when other modalities have failed.
Now, what about the other major injection category? Viscosupplementation. Hyaluronic acid injections. Patients often describe this as going to the doctor to get a lube job for their creaky knee.
The physiological rationale is compelling, honestly. Healthy synovial fluid is highly viscous and elastic, and that rheological property is entirely dependent on a high concentration of endogenous hyaluronic acid.
What does it actually do?
It acts as both a boundary lubricant during flow movements and a shock absorber during rapid impact. In the osteoarthritic joint, the concentration and the molecular weight of the endogenous hyaluronic acid plummet. The fluid becomes watery and loses its protective qualities.
So the theoretical solution is exogenous replacement. Inject thick, high molecular weight hyaluronic acid, often derived from rooster combs or biofermentation, directly into the joint space to restore the viscosity. But the clinical consensus guidelines I'm reading are remarkably hostile to this practice. They explicitly prefer glucocorticoids over hyaluronic acid. Why?
The clinical reality has largely failed to live up to the physiological theory. First, exogenous hyaluronic acid is cleared from the joint space remarkably quickly, often within a few days, so it doesn't provide a long-lasting structural scaffold.
And second,
The treatment is incredibly burdensome. Unlike a single steroid shot, HA therapy typically requires a series of 3 to 5 weekly injections, which is highly invasive and invites the risk of joint infection.
and it's wildly expensive, but does it actually work?
That is the crux of the controversy. While some individual patients swear by it, rigorous, large-scale, double-blind clinical trials have consistently demonstrated that the efficacy of hyaluronic acid injections often fails to reach a clinically meaningful threshold of improvement when compared to a simple intra-articular placebo injection of saline.
A placebo effect.
The placebo effect of having a doctor repeatedly inject a thick gel into your knee is massive. Given the cost, the required multiple visits, and the marginal benefit over placebo, most major clinical guidelines do not support its routine use.
Speaking of massive placebo effects and expensive interventions with questionable efficacy, we must address the elephant in the retail pharmacy aisle: dietary supplements,
Yes.
specifically the ubiquitous combination of glucosamine and chondroitin. Patients devour these supplements. They are marketed aggressively as chondroprotective agents.
They are everywhere.
The promise is that they don't just mask the pain, they actually provide the raw building blocks to stimulate cartilage repair and halt the disease progression. What does the hard clinical data say?
The data is decisively unsupportive. Glucosamine is an aminomonosaccharide that acts as a substrate for the biosynthesis of glycosaminoglycans, the building blocks of those water-absorbing proteoglycans we discussed earlier.
Right.
The theory is that flooding the system with raw materials will stimulate the chondrocytes to build more cartilage. But comprehensive meta-analyses and massive trials, like the GAA trial, have repeatedly shown inconsistent efficacy.
They don't reliably rebuild cartilage, and for most patients, they don't provide pain relief superior to a placebo.
Exactly.
But patients often argue, it's natural, it's just a supplement, so what's the harm in trying? And this is where the pharmacology text gets genuinely alarming. Natural does not equate to safe. The sources highlight two specific hidden dangers that most patients are completely blind to.
Yeah.
The first involves glucose metabolism.
We have to remember the biochemistry.
Okay.
Glucosamine is an amino sugar. At pharmacological doses, it enters the hexosamine biosynthesis pathway. Increased flux through this pathway has been clinically linked to the induction of insulin resistance in peripheral tissues.
Wow.
Glucosamine can physically alter cellular glucose uptake.
Which means if an overweight patient with poorly controlled type 2 diabetes decides to start taking high-dose glucosamine to fix their knee, they could unknowingly be sabotaging their glycemic control and driving their blood sugar higher.
Precisely. If a diabetic patient insists on trialing glucosamine despite the lack of efficacy data, they must implement vigilant blood glucose monitoring.
What's the second risk?
The second risk is an acute, potentially fatal immunological reaction. Anaphylaxis.
Due to shellfish allergies.
Yes. Most commercially available glucosamine is synthesized by extracting chitin from the exoskeletons of marine life, specifically crab, lobster, and shrimp shells.
So a patient with a severe Ig-mediated shellfish allergy could walk into a supermarket, buy a joint health supplement off the shelf, take it, and go into anaphylactic shock.
The risk is substantial. Now, immunologically speaking, true shellfish allergies are typically triggered by the tropomyosin proteins in the meat of the animal, not the ketone carbohydrate in the shell. Therefore, a highly purified glucosamine extract theoretically poses minimal risk. However, dietary supplements in the United States are not subjected to the rigorous FDA pre-market approval and manufacturing standards that prescription drugs undergo.
Purity is highly variable.
Exactly. Cross-contamination with shellfish meat proteins during the extraction process is a very real possibility. We must explicitly warn any patient with a shellfish allergy to absolutely avoid these products.
It's a stark reminder that we are dealing with potent biochemicals regardless of the marketing label. Okay, we have systematically moved through the entire algorithm.
We have.
We've optimized the biomechanics, we've utilized topicals, we've navigated the NSAID minefield, we've debated APAP and Duloxetine, and we've deployed localized injections. What happens when a patient reaches the absolute end of the algorithm?
When their joint is structurally obliterated, the pain is intractable, and they have failed all conservative therapies.
Right. Let's tackle the last resorts, opioids.
The integration of opioids into the chronic, non-cancer pain algorithm has undergone a radical, necessary retraction over the last decade, driven largely by CDC guidelines.
What's the consensus now?
The consensus is now unambiguous. Opioids are absolutely contraindicated as a first, second, or even third-line therapy for osteoarthritis.
The physiological argument against them for OA is incredibly strong. Opioids bind to the mu-opioid receptors in the central nervous system to block pain perception, but they do nothing for the peripheral inflammation.
Nothing at all.
And over time, the nervous system downregulates those receptors. Tolerance builds rapidly. The patient needs higher and higher doses just to achieve the same baseline relief.
And worse, chronic opioid exposure can induce opioid-induced hyperalgesia, where the medication actually makes the nervous system more sensitive to pain.
That's devastating.
It is. You combine that paradoxical effect with the catastrophic risks of physical dependence, respiratory depression, severe constipation, and the potential for addiction, and the risk-to-benefit ratio for a chronic, lifelong disease like OA is completely unjustifiable.
But the guidelines do carve out one tiny, highly specific exception for a drug called tramadol. Why does tramadol get a conditional pass?
Tramadol is an atypical analgesic. It is a synthetic, centrally acting molecule with a dual mechanism of action.
Dual mechanism.
Yes, it is a weak agonist at the mu-opioid receptor, providing some traditional opioid analgesia. But its parent molecule and its active metabolites also inhibit the reuptake of both serotonin and norepinephrine in the spinal cord.
Just like Duloxetine.
Exactly. It leverages that descending inhibitory pain pathway.
Ah.
Because of this dual mechanism, clinical trials show tramadol provides a modest benefit for OA pain without the profound respiratory depression associated with strong opioids like oxycodone or morphine.
I see.
It is the only opioid-like medication recommended to be considered if all other pharmacological options are exhausted or contraindicated.
But that serotonin reuptake inhibition introduces a terrifying potential drug interaction, doesn't it? Serotonin syndrome.
It is a medical emergency. If a patient's already taking a standard SSRI for depression or an SNRI like duloxetine for their joint pain, their synaptic clefts are already saturated with serotonin.
So if a clinician carelessly adds tramadol to the regimen for breakthrough pain,
It acts as the tipping point. The central nervous system is flooded with an overwhelming excess of serotonin.
and the clinical presentation of serotonin syndrome is aggressive, the autonomic nervous system goes haywire.
The patient presents with altered mental status, agitation, confusion, hallucinations. They develop profound autonomic instability, rapid tachycardia, wild fluctuations in blood pressure, hyperthermia.
And neuromuscular abnormalities like hyperreflexia, muscle rigidity, and tremors.
If the offending agents aren't immediately discontinued and supportive care initiated, it can quickly progress to seizures, coma, and death. Tramadol is not a benign, weak opioid. It requires immense pharmacological respect.
So if pharmacology has reached its absolute limit, the only remaining option is to fundamentally alter the anatomical hardware, surgery.
Total joint arthroplasty, joint replacement surgery. Right.
For severe end-stage hip or knee osteoarthritis that has entirely destroyed the patient's quality of life, it is one of the most successful life-altering procedures in modern medicine.
The orthopedic surgeon literally resects the eburnated bone and degraded cartilage and replaces the articular surfaces with highly engineered metal alloys and high-density polyethylene plastics.
It eliminates the bone-on-bone friction entirely, providing profound pain relief and functional restoration.
But the textbook draws a very hard line against a different, less invasive type of surgery that used to be incredibly popular: arthroscopic surgical debridement.
Oh, yes.
That's the procedure where a surgeon inserts a tiny camera and a mechanical shaver into the knee and basically vacuums out all the fibrillated cartilage, inflammatory debris, and loose bodies.
That's the one.
It sounds completely logical. Clean out the war zone. Why do the guidelines strongly recommend against it?
Because rigorous application of the scientific method proved it was largely an illusion.
An illusion. For decades, surgeons performed millions of these clean-out procedures, and patients reported feeling better. But then, researchers conducted randomized, double-blind, sham-controlled trials.
Sham surgery. They cut the patient open but didn't actually do the procedure.
Yes. In the control group, the surgeon made the arthroscopic incisions, splashed some saline around, and stitched them back up without debriding any cartilage.
And the patients didn't know.
The patients didn't know which procedure they received. The results were paradigm shifting. The patients who received the sham surgery experienced the exact same long-term pain relief and functional improvement as the patients who received the actual debridement.
So the benefit was almost entirely a placebo effect.
A placebo effect, combined with the forced rest and physical therapy required post-operatively. Given the inherent risks of anesthesia and joint infection, arthroscopic debridement for general knee OA provides no superior clinical outcome and is generally abandoned.
We have covered an immense amount of ground. We've mapped the cellular pathology, the biomechanics, the complex pharmacokinetics of half a dozen drug classes, and surgical interventions.
We certainly have.
But as a medical student, I know that theoretical knowledge is useless if I can't synthesize it and apply it to a complex, real-world human being. Let's look at Patient Encounter Part 2 from the clinical sources. This is the ultimate test.
Okay, let's walk through it.
We have a 68-year-old female presenting to the primary care clinic. She needs treatment for worsening OA in her right knee and left hip. But we are not treating a joint in a vacuum. We are treating a highly compromised metabolic ecosystem.
Always.
She's obese with a BMI of 32. She has essential hypertension. She has had type 2 diabetes for 22 years, which has led to peripheral neuropathy. She has chronic kidney disease, stage 3. She has COPD. She has hyperlipidemia. And she has a documented history of a gastrointestinal bleed.
This is a standard Tuesday morning in a primary care or geriatrics clinic. Comorbidities dictate absolutely every clinical decision you make. We must deploy the pharmacist's patient care process systematically.
First, we collect.
Right. We look at her vitals and labs. Her blood pressure is currently controlled at 1/3/76, maintained by an angiotensin receptor blocker, losartan, and a thiazide diuretic. Her estimated glomerular filtration rate, her eGFR, is 38 ll-man, confirming moderate stage 3 kidney disease.
Step 2, assess. We have to identify the absolute contraindications. I am looking at her history of a GI bleed and her stage 3 CKD, and my immediate deduction is that oral NSAIDs are a lethal threat to this patient.
Absolutely lethal.
But I want to understand the exact renal mechanism. If I gave her an oral pill of naproxen right now, how exactly does it destroy her failing kidney?
It creates a perfect storm of renal ischemia. Let's look at the glomerulus, the actual filtration unit of the kidney. Blood flows into the filter through the afferent arteriole and exits through the efferent arteriole. In a patient with established kidney disease, the kidney is struggling to maintain enough pressure inside that filter to keep cleaning the blood. To compensate, the kidney relies heavily on local KOX1-derived prostaglandins to constantly dilate or hold open that incoming afferent arteriole, ensuring maximum blood flow enters the filter.
So the prostaglandins are the only thing keeping the supply line open.
Exactly. Yeah. Now, consider her medications. She is on losartan. Losartan blocks angiotensin II, which naturally dilates the exiting efferent arteriole. So the exit pipe is wide open, dropping the pressure.
And if you introduce an oral NSAI,
you completely shut down prostaglandin synthesis. The incoming afferent arteriole clamps shut.
The supply line is choked off and the exit line is wide open. The filtration pressure drops to 0.
The glomerulus is starved of blood. It is a phenomenon known as the triple whammy, an NSAI, an ARB or ACE inhibitor, and a diuretic combined. In a patient with an eGFR of 38, an oral NSAID could precipitate acute catastrophic renal failure within days.
Furthermore, her history of a GI bleed means an NSAID could rapidly induce a fatal gastric hemorrhage.
So oral NSAIDs are absolutely unequivocally out.
Step 3, plan. We formulate the intervention. We start with a non-pharm foundation.
Because her BMI is 32, we aggressively pursue a structured weight loss and physical therapy program, utilizing aquatic therapy to accommodate her severe joint pain without triggering a COPD exacerbation.
For her right knee, which is a superficial joint, we have a clear pharmacological path.
We prescribe topical diclofenac gel. The systemic absorption is negligible. It will penetrate the knee capsule to provide localized relief, but it will not reach her bloodstream in sufficient concentrations to choke off her afferent arterioles or ulcerate her stomach.
But the topical gel won't penetrate the deep adipose and muscle tissue over her left hip, and we can't give her oral NSAIDs. What is the systemic solution for the hip?
We look at her comorbidities for synergistic opportunity. Her chart notes she has peripheral neuropathy, a painful nerve condition caused by her 22-year history of diabetes.
This makes her the perfect candidate for duloxetine.
The SNRI, yes. Duloxetine is FDA approved for both musculoskeletal OA pain and diabetic peripheral neuropathy. A single daily oral dose will increase serotonin and norepinephrine in her spinal cord, dampening the central pain signals from her degrading hip and soothing the burning nerve pain in her feet simultaneously, entirely bypassing her vulnerable kidneys and stomach.
If she experiences a severe, acute exacerbation in that hip while waiting for the duloxetine to reach steady-state efficacy, we have the intra-articular glucocorticoid injection in reserve, strictly limiting it to one injection to avoid accelerating the cartilage destruction.
That is a masterfully formulated, highly individualized care plan.
And the final step of the care process, follow-up and monitoring, because writing the prescription is just the beginning of the experiment. The guidelines provide strict monitoring parameters for high-risk patients.
We must actively monitor both efficacy and safety. For efficacy, we utilize objective metrics. We ask her to rate her pain on a visual analog scale at baseline and at follow-up. We measure her actual range of motion and time her 50-foot walking speed to see if functionality is returning.
And for safety.
If we had initiated an oral NSAID in a different hypertensive patient, we would be mandated to monitor their blood pressure closely at baseline every 2 to 4 weeks for the first few months, and periodically thereafter watching for edema, which indicates renal fluid retention.
For our patient on duloxetine, we monitor for central nervous system side effects like nausea or dizziness. And because she is diabetic, we ensure she is completely avoiding glucosamine supplements that could alter her glycemic control, monitoring her HbA1c closely.
You aren't just treating a joint, you are managing a highly volatile, systemic, metabolic ecosystem.
Well, this has been an extraordinary clinical rotation. Thank you for guiding me through the reality of this disease.
It is my pleasure.
To summarize our deep dive for everyone listening, osteoarthritis is not a passive rusting of the joints. It's an active, destructive remodeling of the cartilage and the underlying bone. The absolute foundation of care, the only intervention that modifies the mechanical destruction, is non-pharmacologic specifically, exponential weight loss and targeted physical therapy. When we move to drugs, we prioritize topical NSAIDs like diclofenac for superficial joints to spare the patient's stomach, heart, and kidneys.
We view oral NSAIDs with extreme caution due to their profound GI and cardiovascular toxicities, and we recognize that acetaminophen's peripheral efficacy is a myth.
We utilize targeted therapies like duloxetine to rewrite the central pain processing, we deploy steroid injections with intense restraint, and we rigorously avoid the unregulated trap of dietary supplements. Above all, we individualize the care plan to navigate the patient's specific metabolic comorbidities safely.
It is a complex, evolving landscape, and understanding the mechanisms is the only way to navigate it effectively. But I want to leave you, the listener, with a final provocative thought regarding the future of everything we just discussed. We spent this entire deep dive analyzing the murky, imperfect nature of diagnosing and treating this chronic disease. And if you step back and look at the pharmacology, from the topicals to the NSAIDs to duloxetine to the injections, every single chemical tool we have is fundamentally just a mask.
A Band-Aid.
They are highly sophisticated, sometimes dangerous ways of muting the fire alarm while the cartilage continues to degrade, the collagen net tears, and the bone turns to ivory. As our global population ages and obesity rates continue to rise, OA is becoming an inescapable, debilitating epidemic.
The current paradigm is unsustainable.
So the question you must ask is, rather than just searching for a safer painkiller to mask the symptoms of joint destruction, how long until the future of medicine shifts entirely away from suppression and toward true regenerative medicine?
We are on the precipice of therapies utilizing mesenchymal stem cells, autologous chondrocyte implantation, and targeted gene therapies designed to actually regrow hyaline cartilage and halt the metabolic degradation of the subchondral bone.
Imagine a future where we don't just watch the joint space disappear on an X-ray, but actually watch the living tissue rebuild itself.
That is the horizon we must aim for.